I'm happy to have all of you here. So today I'll talk more of management strategies as Dr. Shigami has dealt with more of the investigation part. And as we all know, pediatric cataract care is not very straightforward. And we'll be discussing more about surgeries in this talk, but I want to stress that surgery itself is just only one step among the many aimed at achieving normal visual function over a long lifespan. So these patients, they need regular follow-up and constant monitoring. And that is why sometimes there is a concept that I know cataract surgery, why can't I do for pediatric cataracts? So that's usually done outside when young surgeons, they feel that it is, they have a lot of skill and they can always do surgeries in young children. So the surgery itself is, if done fine, is fine, but the follow-up is very important. So time consuming, but very rewarding. So the questions to be answered when you see a cataract with child with pediatric cataract will be the cause of the cataract, association of any ocular or systemic anomaly, need for further lab investigation, whether surgery at all is needed or not. So timing of surgery, type of surgery and the IOL power, estimated visual prognosis that you need to tell these apprehensive patients, and follow-ups, how frequent and what to look for. So we'll be dealing with 4, 5, 6, and 8th point. So need for surgery. So need for surgery depends upon the results of the visual function test. Morphology of the cataract is very important. Centrally, very dense cataracts, we need to operate early. Presence of strabismus and nystagmus always tells us that time is of the essence. And cataract more than 3 millimeter in the visual axis is also one you need to operate, and inability to read the fundus details through undilated pupil. And at least we are very sure about the contraindications. Age less than 7 months, we don't want to keep an IOL implant. Very small eyes, corneal diameter less than 9 millimeter, and eyes with bad trauma, keeping the IOL as a primary procedure. So timing of surgery, unilateral cataracts, now we do it around 4 to 6 weeks, almost like 1 to 1.5 months. Since our anesthesia has progressed a lot and we have very good anesthetist setup, so this timing has really reduced. In bilateral cases, we do the first eye at 4 to 6 weeks, and we give a time of at least 2 weeks to 3 weeks before we do the second eye. So this is very important. I want the postgraduates to give more attention to this slide. So less than 1 year, we'll be doing a lens aspiration. We'll do a posterior capsular rhexis and anterior vitrectomy. So we'll not keep the lens less than 1 year if it is bilateral. 2 to 6 years, apart from lens aspiration, posterior capsular rhexis and anterior vitrectomy will place an IOL. And more than 6 years, the teaching is you do a lens aspiration and place an IOL. We won't do a posterior capsular rhexis and vitrectomy. But practically speaking, when we operate on these older children less than 6 years, even though they can, PCO is 100%. So anyway, you have to do a posterior capsule management post-op. So what we see is when we do yak cap, there is a lot of lens fitting. Sometimes the capsule breaks, but it doesn't come down because of the the gel-like vitreous, not like our adult cases where it just falls off after you do a capsulotomy. So there are practical difficulties. So usually we try to do PPC and vitrectomy even if they are 15 years of age. So intraoperative challenges, yes, low scleral rigidity, elastic posterior and anterior capsule, and a lot of surprises sometimes on the table. So I'll be sharing a few videos and explaining certain things. So you just keep a watch and then finally we'll summarize. So this is a 3-month-old child. We are not planning to place an IOL. And here we are going to do a limbal-based incision. Why limbal-based? Because entry is, manipulations are easy. So we use a 15 blade, just put a incision exactly near the limbus and we enter through the 15 blade side port. We don't enter through the keratome because we don't want the corneal entry to be big. So then definitely we'll have to stain the capsule. In very young children, it's sometimes very difficult to do a regular rhexis. So we usually do a can opener and then try to remove the cataract, because if you keep pulling the capsule too much, it might lead to dialysis. And you see that these cataracts are not soft as expected. So they are usually sometimes very calcified. And we have done a PPC and we are doing a vitrectomy. And then definitely these limbal sutures need to be, sections need to be sutured. So this is less than 1 year. We'll do a lens aspiration, we'll do a PPC, and we'll do a vitrectomy. So we'll not place an IOL. So what about when we have very small pupil in infants? Should we use iris hoops? Definitely we should use, because the outcome of surgery is very important. Here you will see that we'll enter the cornea at a longer distance. The length of the side port will be slightly more, so that you need not hydrate it when you, you need not suture it when you want to close it. But the iris hooks will not reach the iris, so you'll have to put visco below the iris and try to lift the iris to catch it and expand it. And this is very important because we don't want to do any blind surgeries in children or very gross surgeries. So if at all you want to use iris hooks, we should use, and this is the way of using it. So this is the common surgery that we usually do, because the incidence of cataract and the presentations are slightly at a later date. So this is a 6-year-old child where we have done a clear corneal incision. We have stained the capsule, and now we are going to start the rhexis. As you see, the nick is given at an area where you can go and hold it with the forceps. And this is a rhexis forceps. So grasping, regrasping, and sizing of the rhexis is also important. It should not be very large. It should be able to encapsulate the optic, at least for 1 to 1.5 diameter length. And we do an aspiration. You use the Simcoe. You can also use the aspirator. And for the rhexis, we try to make a small opening first. You can always use visco on the cornea for better visibility. And you'll see the amount of pressure and direction of the pull that I'm going to give on the PC. It is more elastic, and I'll be more pulling it towards the center rather than trying to rotate it. So once it is done, a thorough vitrectomy is done. So the vitrectomy is done along the edges of the PPC, and then we go towards the center. And here I am placing a single piece intraocular lens in the back between the PPC and the anterior capsule, and we have centered it. So this is the anterior capsular rhexis, which is around the lens, and it is encapsulating the optic. And this is the central PPC, which is occupying the central 3 to 4 millimeters. So because the scleral rigidity is better in slightly older children, we try to put a clear corneal incision and then hydrate it. We try to avoid putting side ports. One, because sometimes it might leak, and second, we need to suture it. And once we suture it, we have to remove it. So that becomes a problem. So here I am going to talk about a traumatic cataract, how we are trying to save as much of anterior capsule as possible. So this side, there is no anterior capsule, it is torn. So you're making a nick, cutting the edges and trying to make a rhexis. The idea is to save as much of anterior capsule as possible. And after aspiration, you see that the anterior capsule is completely torn. So we are proceeding with the rhexis. And then after vitrectomy, we are trying to place a 3-piece IOL. So since we can't place an IOL in the bank, we are putting a 3-piece IOL, and we capture the optic in the margins of the PPC. So you can see that I'm pressing the optic, pushing it there so that this part of the PPC comes inside. You see the spindle-shaped appearance of the PPC being captured on the optic. And this is the ALC capsule which are torn. The main aim is to give stability to the IOL. So if it is placed in the sulcus and just left without optic capture, you might have a lot of post-op complications. So you make a PPC and you just push the IOL slowly so that the optic only goes behind the PPC. So this is one way of, and here we have a traumatic cataract with a very, very thin PC. You see that the PC is very calcified. It's very thin. So in these cases also, we will avoid putting a single piece IOL in the lens because sometimes PPC might extend and you might have a dropped IOL. So even though we are doing a rhexis, posterior capsular rhexis, and a vitrectomy, still we end up putting a 3-piece IOL in the sulcus. And this is the area of trauma, corneal trauma, and I'm pushing the optic behind the anterior capsule and the posterior capsule so that it is stabilized. So this is the posterior capsule, a spindle-shaped appearance, and this is the anterior capsule that is also behind, the optic is behind both of them. So the concept is both of them get fused and the lens cells get trapped inside and they don't move towards the center of the optic, and we have a clear optic for a long time. This is a very peculiar case where sometimes you end up seeing a cataract with a posterior capsule dehiscence already is there. So in these cases, we try to use a bimanual technique, try to remove all the anterior lens capsules from the center area where the defect is there. And then we place an IOL in the sulcus after vitrectomy. So you'll see that the UST itself, you'll see that there is the posterior capsule is ruptured and the cortical matters are diffusing into the vitreous. So sometimes when you see a anterior lens surface which is going back, there is a gap and you are able to see a defect, then you have to be more careful so that you don't lose your cortex into the vitreous. So then coming to the other aspect of pediatric cataract management will be secondary IOLs. So usually these secondary IOLs are done either after leaving the patient aphakic and then you are planning to keep an IOL, or following trauma. So the primary repair has been done as you see here, and then they have aspirated the lens. Now we are planning for a secondary IOL. So here we will be releasing all the Synec, and here I wanted to show you how a posterior capsule can also be extended with the help of your vitrector, or you can do a posterior capsular rhexis with the help of your vitrector. You see that we are trying to increase the size. And calcified areas also can be cut with the vitrector. We are placing the IOL in the back, in the sulcus. And here also we are pushing the optic behind the PC defect to cause an optic capture. So now a newer concept of optic capture without vitrectomy is being proposed. So where the surgery itself becomes less machine dependent, because when we go to very underdeveloped countries like Nigeria and other places, the main drawback of doing pediatric cataract is they don't have a vitrectomy machine, and it's very difficult to maintain a vitrectomy machine, sterilize it, and a lot of other things are involved. So this new concept of not doing a vitrectomy and trying to capture the optic into the PPC margin. So we have removed the cortex. This is the torn anterior capsule. We are doing the rhexis. Without vitrectomy, we are putting the lens in the sulcus. And you see it's slightly difficult to push the IOL between the PC and the vitreous, but still it is possible. You can see the PC slide coming. You see the margin coming inside, and this side, I'm depressing it and pushing the optic into between the PC and the vitreous. So this is the posterior capsule margins which have been captured, and the optic is behind and the aptic is in the sulcus. So this is done without vitrectomy. So after seeing all these things, when you make a decision, age is an important factor. So it depends upon the type of procedure, whether you're going to do a PPC or vitrectomy or an IOL. Undercorrection has been discussed. And section, usually limbal sections are made when child is less than 6 months for better manipulation. Scleral sections are made at 6 months to 4 years of age. So you can make an incision, do a tunnel and then entry and then suture it. And clear corneal tunnels are made for children more than 5 years. So apart from age, scleral sections are done for difficult cases where there is a lot of manipulations, and a clear corneal will not be an ideal section. In clear corneal, we usually do in cases where it is very clear. Sutures, definitely limbal and scleral sections have to be sutured. So there is no other option. With respect to clear corneal sections, when there is a distortion of the section, we'll have to suture it. If one part of the tunnel is damaged or it is torn, definitely you have to suture it. And AC is not forming tightly also, you have to suture it. And even after vitrectomy, the AC has to be very tight and well formed. So you can't say that because we have done vitrectomy, the eyeball is soft. So after you suture, when you form the AC, it should be hard and normal. So type of sutures, we usually use the 9-0 and 10-0 nylon sutures. Some people prefer using vicryl sutures for clear corneal tunnels. The advantage is it absorbs, but the disadvantage is it collects a lot of mucus because it's a braided suture. So chance for infection is very high and becomes loose fast. It breaks, but it doesn't go off. It's still there dangling around, collecting infection. So that is also a disadvantage. Scarring is also more because it's a braided suture. So anterior capsule management, staining is very important. As I told, the initial nick has to be in the proper clock cover so that you can go and hold it. So you place it in an area where you are not able to access it, then it becomes a problem. So rhexis faucets definitely helps, and it's very handy. An adequate size has to be there. And extension of rhexis is not the end of surgery. As you would have seen, even if the anterior capsule gets extended during your manipulation, you don't have to really be very worried because you always have the posterior capsule to capture. So posterior capsule management, visualization is very important. So visco over the cornea. Don't fill it very deep when you start the rhexis. Otherwise, it goes down and it is very difficult to puncture it. So you just place enough visco so that it becomes flat so that you'll be able to access it easily. Use the cystitome horizontally to hook the PC and then tear it. It is not like your anterior capsular rhexis. You have to use it horizontally, hook it and then tear it. Avoid very large posterior capsular rhexis. And vitrector can also be used or should be used while doing posterior capsular rhexis in cases where there is calcification. So regarding automated vitrectomy, classical teaching is two-port vitrectomy. It can be done through the same section also to avoid side ports in children. And endpoint of vitrectomy is always a question mark because it's a very, very blind procedure. Blind in the sense it's not that you don't see and cut. You cut, but you are not very sure whether you are cutting what. So it's vitreous is very clear. So the teaching is you go around the margins and along the central part and slightly go down. And usually the cut rate is maximum for the particular machine which you are using. Vacuum around 250 to 300 millimeters of HG, and aspiration flow rate is around like 25 to 30. So type of IOL, preferred choice is acrylic monofocal IOL. So torics, multifocals and all, because as you heard about the myopia progression, undercorrection, and lens positional changes which can happen because of the bag contraction. These are all not indicated. And the single piece is definitely has to be placed in the bag. Only you have to use single piece only if there is a bag. So 3-piece, you can place it in the bag and also in the sulcus, and it is very helpful to do the optic capture with the help of a 3-piece lens. So optic capture is a must only if the posterior capsule is available. Please don't put the lens in the sulcus and then just leave it like that. Without vitrectomy, yes, if there is no significant vitreous disturbance, you can always capture it without doing vitrectomy, and it's a machine independent procedure. So when we deal with complicated cataracts, you see that apart from keeping the IOL, we have to also manage the pupil. So pupilloplasty is also very important. Here we are using a straight needle with a Prolene suture and using the Sipser knot to retrieve the suture and then slide the knot into the anterior chamber so that the IOL is placed and also the pupil is round and the child doesn't have photophobia. So other thing which we commonly come across is microspherophakia, where the zonules are weak and the lens subluxates. So we are using a scleral incision. As I told you, we'll make a small incision near the limbus, do a small tunnel and entry. And here I am just going to use the visco to just go behind the lens and just press the posterior lip so that the lens comes out, and then we do a suturing and vitrectomy. So this is how subluxated lens in the anterior chamber is managed. Subluxated lens as such, in case of Marfan's and other syndromes, now we usually don't do lot of difficult procedures like CTS, CTR, because we see that at some point of time it all breaks and we lose the lens. So here what we do is we do a lens aspiration from the anterior side. We are trying to breach the anterior capsule and do a rhexis, and then we do the cortex aspiration. And we use the vitrector only to cut the bag, because as you saw in microspherophakia, we can't pull the bag outside because rest of the zonules will be very intact and tight. So if you do any hard manipulations, you end up with dialysis in the retina or breaks or RD. So we don't pull the lens outside. We just aspirate it and cut the rest of the bag with the help of a vitrectomy cutter. And this is a case of trauma where we are using iris hooks to stabilize the capsular area where there is a big dialysis before we put a CTR. So this is important, and the iris hooks can be used for that purpose also. So once you stabilize, then you can put the CTR and then put an IOL in the, and we are just extending the capsular opening so that we can place the IOL without difficulty. And IOL in the back. So sometimes in dialysis, you have to be very careful. So the advantage in a childhood traumatic cataract with dialysis is the other areas are quite strong. But still, when you want to put a CTR, you will have to make sure that you stabilize it. And what should be done at each follow-up? So visual acuity testing is very important, appropriate age, slit clamp examination for visual axis opacification, IOP measurement, and also we have to keep looking for signs of intraocular pressure like sudden increase in axial length or sudden change in the refractive error also will point to an increased IOP, refraction, and fundus. So refraction can be done at all age groups. So watchful follow-up for correction of aphakia and pseudophakia. Amblyopia management is very essential. Detection and management of visual axis opacification and management of low vision. And the take-home message will be the importance of optic capture. So this is what happens if you put it in the sulcus. You will see that the IOL has come out and the iris has gone and got stuck to the posterior capsule. So it has been released and sutures has been put for doing a pupilloplasty. But still it is very, it takes a lot of effort, work, and time to treat these eyes. So, and the inflammation is also very high. Sometimes they end up amblyopic. So always try to do an optic capture if you are trying to put the IOL in the sulcus. Thank you.